Welcome to the UK Dementia and Palliative Care Conference 2025 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. Supporting people living with dementia, experiencing bereavement and loss. Facilitated by Tracey Carter, Head of Dementia Care and Wellbeing, Hallmark Care Homes.
So my name is Tracey Carter. I'm Head of Dementia Care and Wellbeing for Hallmark Care Homes. All my working life as an adult has been spent within health and social care. I'm a nurse by profession. I've been a nurse for over 35 years. I was a child student, as I'm sure you can appreciate. And the last 17 or 18 years or so have been spent working with people living with dementia and affected by dementia as well. And it's been the joy of my life, really, to support families and people living with dementia. So I'm here to talk to you about supporting people with dementia experiencing bereavement and loss. And it's a subject, really, that has little kind of focus. And I think the reason that is because people living with dementia are a difficult group to kind of work with and understand and research in terms of their emotional response and ability to go through the grieving and bereavement process. So as we go through the presentation, you'll see that the pool of resources available for us as professionals to understand and learn from is quite small. And I'll move forward to present to you as well a case study from a piece of work I did with a family probably about 6 or 7 years ago now, when I was working as an Admiral nurse supporting a large group of care homes. So I don't want to kind of preach to the converted. We all know what dementia is and how it can affect the individual. But I think it's important for us to just kind of focus ourselves down on the kind of broad effect of dementia on the individual. Of course, it goes without saying that dementia is individual to the individual. It's true what Tom Kitwood said, that when you've met one person with dementia, you've met one person with dementia. So it's very individual to the person. But in broad general terms, dementia, as we know, disrupts cognitive processes, particularly memory and reasoning. Short-term memory is often impaired and affected before long-term memory. And what remains intact for longer is a person's emotional memory and emotional functioning. So very much a person living with dementia, their sense of reality, their sense of here and now is very much within the emotional, spiritual and psychological realm. So then when we think about the grieving process, and here I'm just drawing on the Kubler-Ross model, but other models exist. We acknowledge and we know that grief and bereavement itself is a dynamic emotional process. There's no right or wrong way to grieve. It's a process that's almost cyclical, and we can revisit various aspects of the grieving process as we go through it. So there's kind of no beginning and no end, as it were, really. It's very cyclical. And it's, again, a bit like dementia. It's very individual to the person themselves going through it. Although I'm a nurse by profession, my master's is in behaviour analysis and person-centred intervention. So when I'm trying to fathom out why a person is behaving and responding and acting in the way they are, I always start to think of it from the first person's perspective and think about how would I feel if I was in this situation and responding to that. So in thinking about the grieving process, I drew from my own experience of experiencing bereavement and grieving. And for me, going through the process that still continues to this day, I lost my mother and father nearly 30 years ago now, and I lost my two older sisters 2 years ago. And whenever you experience another bereavement, you start to go through that cycle again, and it brings up the effect of previous bereavement and loss as well. So when you think about a person living with dementia, and when you think about the grieving process, marrying the two together can be a very complex and mixed presentation. When I think about my own experience, and when I get to the stage of acceptance, I reflected on that and thought, actually, I'm still maintaining a relationship with my loved ones who have now passed and gone. It's a very different relationship because it's based on my emotional memories and responses and within the spiritual realm. And to this day, I will sit and have a cup of tea with my mum, who's passed nearly 30 years ago, and talk to my mum about the kind of day I've had, the problems I've got, the successes that I've had. So the relationship that I have with my mother still continues on an emotional and spiritual level. And it occurred to me that for a person living with dementia, all their relationships are occurring on that emotional and spiritual dimension, because they may have lost the ability to understand that mum and dad, their mother and father, have been passed and gone for 40 or 50 years. They may grieve the loss of their young children who are now 50, 60-year-old adults, and they no longer recognise them as their children. And they may not understand or accept the fact that their spouse comes to visit them once or twice a week now and isn't living with them on a full-time basis. So that needs to be taken on board and considered when we're thinking about how a person living with dementia can process and go through that grieving process. So, if we look at current research, as I said earlier, little exists. And what does exist? When I first started to explore, the closest thing I could find initially was research around people living with an intellectual disability and subsequent cognitive difficulties and impairments. As I said, studies in general highlighted challenges in studying the grieving process for people living with dementia. They were a difficult group to kind of work with and research because there was so much variation across the population. And the research that I was able to access did emphasise the need for an individualised, compassionate support strategies and approach. So if we look at the first, I've given full references of these articles at the end of the presentation. O'Riordan et al. In 2022 reviewed 18 studies on the grief reaction of adults with an intellectual disability. They found that people with an intellectual disability were more likely to experience complicated grief reactions that was often underestimated by the people supporting them, both families and professional carers. They called for further research into diagnostic criteria and appropriate interventions as well. I then found a research study that did focus on people living with dementia. Watanabe and Sewer in 2017 studied the mourning process of older adults living with dementia who had lost a spouse. And they found that the mourning process and the behaviour of people differed according to the stage of dementia that the person was at. So they highlighted that traditional grief models may not apply to people with dementia. So then I took a look at therapeutic approaches because I needed to understand what therapeutic approaches would help and support a person living with dementia. And James et al. In 2019 looked at the use of therapeutic lying in dementia care, quite a controversial topic. But the study found that the use of therapeutic lying was quite widespread, particularly across the care home sector. But they found that there was a lack of clarity in terms of when it should be used, how it should be used, and if there were to be any issues around best practice, what that looked like, sounded like and felt like. It also found that often carers just didn't know what a therapeutic lie was. They didn't understand how to apply this, when to apply it, and what use it would be. And they found that often it was used where there were staffing shortages. And it was more about the need of the care team than it was about the need of the individual. I then looked at validation therapy. And this study from Enderman and Schnaps from 2016 was a study that was conducted in a care facility as well, a long-term care facility. And they found that by using this validation of emotion approach, that overall there was a reduction of the use of psychoactive medication. It helped people with dementia cope with transitions and emotional distress, and it strengthened the person-centred care approaches. So it had a really good effect. Then I looked at more recent research studies, and they were born out of the COVID-19 situation that we had 5 years ago. And they looked at more blended approaches rather than one or two significant approaches to be used. Duffy and Ballantine focused on bereavement support for individuals with dementia during the COVID-19 pandemic who had lost loved ones as a result of them contracting COVID. They again emphasised the importance of individualised support based on the stage of dementia that the person was experiencing. And they recommended that sharing the news of a loved one's passing, of a loved one's death, as soon as was possible was really key and really important. They felt that providing consistent responses, because the likelihood was that the person would ask again, would forget that their loved one had passed away, would not be able to store that factual information as a memory. And the next day or a couple of hours after, they'd be asking again where their loved one was. So they recommended a consistent approach and response. They also recommended the use of reminiscence exercises and activities, gentle redirection, if distress persisted as well. Karen Harrison Denning in 2023 wrote a book and dedicated chapters to different areas of everything you want to know about dementia. And one of them was looking at the family perspective of dementia and grief. And again, drawing on the experiences of a family who lost their father during the COVID pandemic, how they supported their mother through that process. And again, that highlighted the need for a blended approach and how that family were able to manage the repeated episodes of mum asking where dad was, that she needed to be with dad, that she was worried and frightened that dad was alone because she'd forgotten that dad had passed away. And what was evident there was that the whole family were going through the grieving process. So it was really difficult for the family to not only support mum, but also they were going through repeated grieving process as mum was going through it as well. And they used a blended approach of consistent response to mum. And they also introduced the use of therapeutic lying because as things got quite difficult, they found that mum's sleeping pattern altered, that she wasn't eating and drinking, and that created a vicious circle where she got more and more agitated and more distressed. So at times when her levels of distress were increased, they introduced the use of therapeutic lying and saying that dad is okay, don't worry about him, he's safe, in order to calm mum down so that she would get some rest and nutrition. And they also used reminiscence and mementos as well. And the thing, it was an Asian family, and the thing that they said was really difficult was they were denied access to their traditional burial and death kind of processes as well, which was something that was quite significant, and they felt extended mum's kind of difficulties in coming to terms with the fact that dad had passed away. So very quickly I will move forward to give you some details and background of a case study based on a piece of extended work I did with a family and a care team of an individual who was really struggling to accept and understand the loss of his wife. So the reason for referral was, again, the names have been changed and the photos aren't of the individuals. Albert was a care home resident living with vascular dementia, was exhibiting extreme distress since the death of his wife, Emily. The behaviours that were reported included repeatedly asking to see Emily, becoming more and more agitated and aggressive, hitting out, pushing anybody who was getting in his way, and the physical risks were increasing. He was more likely to have falls, losing weight because he wasn't eating and drinking properly, and awake for extended periods during the night. He'd been seen by the doctor and he'd been prescribed PRN lorazepam. In terms of the background history, he and his wife Emily moved into the care home at more or less the same time. He was living with dementia, so went to live on the dementia community. But Emily was quite ill with a diagnosis of cancer, and she resided on the nursing community. They would see each other on a day-to-day basis, they'd have meals together or spend time in the afternoon together. But as she started to decline in terms of her health and her frailty, the visits became less frequent and less extended, so his anxiety was already increasing then. She did die, I'm going to say relatively unexpectedly, although it was expected. They didn't expect it as quickly as it actually happened. The family were obviously devastated and grieving, and felt it was in Albert's best interest not to tell him and to lie to him. So the care team were left as anxious and agitated as Albert was, because they just didn't know what to do and what to say to him. And the use of lying, it wasn't therapeutic, but the use of lying was all they had in terms of supporting him through that difficult situation. So, when I got to the care home, it was a pretty fraught situation. So we focused initially on supporting the team to understand how to kind of validate Albert emotionally. But we acknowledged that Albert had the right to grieve and he had the right to know that Emily had passed away. But how we would manage that in the mid to longer term was another story, really. So we had to work quite intensively to support the team, to be able to understand and know how they could do that, but also to work with the family. And it was clear and evident that the family weren't just grieving for the loss of the mum, but they were also grieving for the gradual loss of their dad as well. And they felt at a loss, really. So there had to be a piece of work with the family before we got to the point where we needed to tell Albert that Emily had died. But it was really good working with the family because we could get to understand what Albert's perception and belief around death and dying was pre-dementia. And I've put the phrase there, she's gone to live with the angels, because that was his belief, that it was a northern bloke, a working class northern bloke. She's an angel, is our Emily, and that's where she'll go when she dies. She'll be watching over us all because she's my angel. So they were the words that we used. We used the language that Albert would understand. And yes, it broke his heart when we told him. And it broke the heart of everybody around him as well. And for the first month to 6 weeks, it was a daily occurrence. And he was reliving the fact that Emily had gone. But by working closely with the family and the team around him, we were able to introduce validation to validate his emotional sense of the here and now. We were able to bring in mementos. The family had got like in memoriam cards that they'd given to family members, so we had one of those. He had pictures of Emily in his bedroom, and the team around him would be able to validate him emotionally, take him to his bedroom, have a cup of tea, spend a session with him, talking about Emily, what she meant to him, etc., etc. We were able to work with the GP and the community mental health team in terms of looking at how we used the lorazepam that we didn't actually end up using at all, hardly, but acknowledging that we might need to think about introducing antidepressant medication. But it had a really good outcome, as you can see from that. It was an intensive piece of work. It took 6 months, but we saw a reduction on the impact that grieving process had for Albert. It didn't stop him asking for Emily, but it certainly reduced the intensity, frequency and severity of the difficulties that he had.
Thank you.
Sorry.
That's it for this episode of the UK Dementia and Palliative Care Conference 2025 podcast. A huge thank you to our sponsors, Majestic Holidays, Wallens, Amica Care, MC Hearing and Audley, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.